It is just an honor and a privilege to be in Tel Aviv, Israel, and I get to podcast interview Yuval Zubery, DMD, from Datum Dental. So tell us about your journey. You used to teach in Texas.
Yes. 1991, 1992. Now you know how old I am. And I did 2 years of research and teaching in San Antonio in the perio department. And it was the best time.
Do you have more memories of San Antonio, Texas?
Wow.
I love the boardwalk there.
Yeah.
Was the boardwalk back?
Yes.
Was it back then?
Yes. The river walk.
Yes, the Riverwalk. Love it. So you graduated from dental school at the University of Jerusalem. And so tell us about your private practice and tell us about your journey of how did you end up in Datum Dental?
So the Datum Dental, I actually met at Tel Aviv University in 1992 when I came back from San Antonio. And I actually did the first clinical study on membrane produced with this technology. So it was on periodontal defects back then, actually furcation defects. And the technology continued to develop in Tel Aviv University and was finally commercialized and purchased by a company named Colbar. Colbar continued to develop products and the technology. And in the year 2000, the first membrane called O6 came to the market. O6 was a bovine collagen-based membrane, and it was really long-lasting, almost non-resorbable. Then I joined the company as a consultant, and we continued to develop the product line and brought to the market in 2006 a new membrane called O6 Plus. The change was from porcine collagen, from bovine collagen to porcine collagen, and the membrane was, the cross-linking level was lower than with the O6. What we found out in the studies that we did, both animal and human studies, that the change actually made collagen and membrane that ossified. So in addition to being a barrier for 6 months, and we had ossification of the membrane, and the membrane actually contributed actively to the ossification of the bone graft underneath. So that was in 2006. The company produced other products for medical purposes, especially in the aesthetic field, and had a product, injectable filler, a dermal filler called Evolence. The company was bought by Johnson & Johnson and continued to develop the products and increase the production capacity. But in the year 2009, decided to shut down the company, and the production and the employees were let go, and the production stopped. In 2011, a group of ex-Colbar employees were able to buy the technology and the entire IP from Johnson & Johnson. We started a new company called Datum Dental, and in the year 2004 started production and sales of the new products. Since then, we developed two new products, O6 Volumax and O6 Bone. So the company now has three products: O6 Plus, a dental membrane; O6 Volumax, a dental scaffold; and O6 Bone, that is designed to be a bone substitute for GBR, for augmentation in the maxillofacial area.
So go through each one of those products. And remember, a quarter of the viewers are still in dental school. So some of these abbreviations and terminologies might be going to their head. So go back before your University of Texas days and try to put your dental school student hat on and talk about your three products and what each one of them does.
So what we are trying to do is actually give the dentist, GP, specialists, better materials and better tools to cope with the problem that we all encounter, that is insufficient bony housing for dental implants. We are also in the periodontal regeneration arena, but most of the products at the moment are aimed to the guided bone regeneration procedures. The three products include a dental barrier membrane, and the term barrier is very important because most of the collagen devices, collagen membranes today, are short lasting. That means that the membrane barrier effect is sometimes can vary between 2 weeks to 2 months at the most. And the reason is because this collagen is either non-cross-linked or with a low cross-linking, and that determines the longevity of the device in the site. So O6 Plus is a membrane that will last 6 months and over. That means that every time you open up the site, if you had primary closure, that means first intention healing, and the flap will close within a week or two, you will see the membrane in the site over the new bone. And this is allow you to get a better quality bone. Plus, in cases where you have exposure of the membrane, this membrane will last between 3 to 5 weeks exposed, and will continue to protect the bone graft underneath and allow for more bone formation in the site. So many times you can even leave the O6 Plus membrane deliberately exposed. We call it intentional exposure, and we see a nice outcome with this technique that sometimes is needed to allow preservation of the keratinized tissue, and in cases where we do not want to advance the flap to get primary closure. So this is the O6 Plus. The O6 Volumax is based on the same collagen, and this is again pure collagen. But this is not a barrier. That means that cells and blood vessels can penetrate the material as soon as 2 weeks post-implantation. So we have a device that is thicker than the O6 Plus. It's actually 10 times thicker. It's 2 millimeter thick, and the device will create volume, and eventually, if you wait long enough, between 8 to 12 months, you will have bone. So this device serves as what we call a bone bandage that you can place, for example, on thin buccal walls following placement of implants, and you will get, over time, you will get additional volume and additional bone to protect your implant. Volumax is also used in some cases, in some indications, for gingival augmentation, but this is a technically sensitive use and has to be practiced and understood before you try to do these type of procedures. The third product is O6 bone. O6 bone is actually a sponge. This sponge contains the same collagen, same sugar cross-linked collagen as the O6 Plus and Volumax, and the device will completely ossify, and the ossification is actually in situ. That means that even in areas of the sponge that are not in contact or maybe more distant from the bone, you will see ossification of the device. So it's actually an ossifying, actively ossifying device. This is ideal for procedures like socket preservation. If you place it in a socket, regardless of the number of walls around the device, you will see complete ossification of the device. And in many cases, you will be able to place your implant without additional augmentation. O6 bone is also used for closed or transcrestal sinus elevation, where you can use osteotomes or other techniques to elevate the sinus membrane through the osteotomy. And when you use the O6 bone, you get the advantage of have the material has less tendency to tear the sinus membrane because it's a sponge, it is soft, and following placement, it will also expand in the sinus. So in some cases, you will see additional bone to the original volume that you placed at the day that you place your implants. The third indication is lateral bone augmentation. In that indication, you need a membrane. So we recommend to place O6 Plus over the O6 bone and secure the membrane and the bone underneath with periostal sutures. You cannot suture through these three devices because this collagen is not tissue derived. It is collagen that is extracted from pigs, from porcine tendons, cleaned to a very high level in its molecular form, and only then reconstituted to form these devices. So this is not tissue, you cannot suture through it, and it tends to tear if you handle it aggressively, or should I say, the handling properties are different than other membranes, and there is a learning curve when using these devices.
So now, these would all be two-stage implants where you place the implant. Are you still placing implants, or are you placing these?
Yeah, sure.
And how often are you placing these? Tell them about your history with these.
Every day in the clinic, I use these materials. I use it almost exclusively today. So I have bone, I have a membrane, I have this device, the O6 Volumax, and these materials actually change the way I do my cases. So in the past, I used to do immediate implants, mostly. I would take out teeth, even teeth without buccal walls or missing bony walls, and place the implants and do the augmentation simultaneously. Today, if the patient still has the tooth and needs extraction, I do the extraction, I place the O6 bone, I wait, and I place my implants, many cases without additional augmentation, and in some cases, I just use the Volumax for additional volume or additional protection of the site. So these are actually game changers, I would say, in the way I do my implants today.
And now, what percent of the implants do you place and immediately load?
Very few.
Very few. And explain why.
I've been doing implants in the last 25, almost 30 years now, and I see the failures. And to me, the right way is the long way. I used to do it in the short way. I placed implants, immediate loading, and today I went back to doing staged. The staged approach will allow you to get better quality and quantity of bone around your implant, which is always needed in the long run, because I see implants 15, 20 years post-placement, most of them are losing bone. They are losing bone on the buccal side, you see recessions, you see loss of soft tissue, and I believe that if you place your implants in a properly prepared housing, bony housing, with sufficient keratinized tissue and delayed loading, you get a better long-term outcome with these implants.
And how long do you usually delay the loading?
I take out the tooth, place the implant, 3.5 to 5 months later, I place the O6 bone in the socket. I wait 3.5 to 4 months. I place my implant, and 3-4 months later, we do the restoration. So it's probably delaying the process by 4 months, 3-4 months. So that's the normal.
And does this implant agnostic, or do you prefer a certain implant to go with this product line?
No, you can do any implant.
But what
I'm
implant?
using, in my office, I am using 3 or 4 implant systems because I get referrals. So
Because you're a periodontist.
Because I'm a periodontist, yes.
So,
I do not do my restorations.
So you have 3 or 4 systems because some of your referrals want you to use a certain implant system.
Exactly.
And what are the systems most commonly ask you to use?
I use Zimmer implants for many years. I use MIS V3 implants, which I use in the last. MIS V3.
Which stands for make it simple.
Yeah.
That's an Israeli implant company.
Yeah.
Who bought that? Was that
Dentsply? No, it's a Dentsply company.
How long ago did they buy that?
2 years.
2 years ago?
Maybe 3.
So Zimmer and MIS, which is now Dentsply, and what are the other two?
And then I use Straumann implants.
Straumann.
These are the systems that I currently use. I used to use BioHorizons in the past, and now I use mostly Straumann MIS V3 and the Zimmer implants.
So why do you use less BioHorizons these days?
Because of the restoring dentists, they are not asking for this system.
So
I have good experience with these implants.
Yeah, so as a periodontist, you've got to respond to your referring dentist.
Yes.
And they're mostly asking you to restore with Zimmer, MIS, and
Straumann.
But if a dental student someone just wanted to start implants, they're saying, if I locally buy one system, what would be your top recommendation? Or now when you laughed, is that because it causes channel conflict with you? If someone, are you afraid if you recommended one system, the other systems would get mad?
Because, I feel a little bit uncomfortable because the reason why I changed or the reason why I use these systems is mostly because I'm comfortable with this long term. I have long-term experience with some of these systems, and because of the referring dentist.
Yeah.
So
the patient is always putting pressure on the dentist for immediate. They want everything same day. So what skills how would you advise a dentist to try to convince a patient to wait and long term do it right instead of, because they're always afraid they're going to be able to go down the street and get an immediate load implant.
to me, it's easy because the explanation makes a lot of sense. Because and I heard it from one of the speakers that I really appreciate and look up to. The body cannot do two miracles at a time, so we are never able to predict which patient will have good regenerative potential. Those who may have complications, elderly patients, smokers, and those which you do not expect. So if you do it in a staged approach, you have a lower chance of falling into these pitfalls that I used to fall in the past.
One of the bigger problems with implant dentistry is the people that seem to lose the most teeth and need the most implants usually are your smoking, drinking, the vegan who does yoga every day. So but some of these kids come out of school and they say, well, no, you can't do it if they're a smoker or if they have diabetes or if they're old or all these things. But that tends to be the people who show up at your door missing teeth. So what would you advise younger kids in treatment planning? How do you diagnose if they come in smoking with gum disease and diabetes?
Well, obviously, gum disease, periodontitis is a total uncontrolled periodontitis is a definitely no for implants. You cannot do implants on an active periodontitis patient. So with those, I do not do the implants until I do full mouth scaling and root planning, and I mean deep root planning. I make sure that the patient is brushing properly for some time, not just for a week or two. And with smokers, I insist that those who smoke a package a day, 20 cigarettes per day and over, I'm not doing implants. Just not doing implants.
And what would you say the failure rate is for someone who smokes a pack a day?
I'm not sure about the literature. I'm not fully updated recently, but from my experience, they lose implants and quickly, like 5-7 years, you start to see the complications, and then they lose the implants, and it's second time when you try to do those implants, you're in even worse situation. So it's better in those cases to make sure that the patient is compliant, is coming regularly for dental hygiene, reducing the number of cigarettes per day, try to get below 10 cigarettes, and that it does not have any active periodontitis pockets, as much as we can determine that.
So a big problem with implants is Peri Implantitis.
Exactly.
But I want to go back to treatment planning, because you and I have been doing this for 30 years. And 30 years ago, when we got out of school, periodontists tried to do periodontal procedures. They tried to lay flaps and do the old school network. And then it seemed like somewhere between 1990 and 2000, everybody thought the fastest, easiest way to treat periodontal disease is with titanium. Let's just pull that no good tooth, replace titanium. And then 10 years of doing that, they started realizing we still have the same problem we had in the beginning. So have you noticed yourself as a periodontist that you used to do all perio surgery, then the pendulum swung towards implants, but now you see yourself swinging back towards saving natural teeth with perio?
All along, I was one of the more conservative periodontists. I did mostly scaling and root planning and oral hygiene and maintenance, most of my cases. From time to time, I have a case, or I had a case in the past, where I had like deep intra-bony defect that I believed that I could get good regenerative response in that defect, then I would do surgery. Other than that, very few periodontal surgeries. And I did not pull out teeth. I have patients with 20% bone support that I maintain for many, many years. I believe in the tooth, and the tooth, we know what to do. We can save teeth that look hopeless. With implants, once it starts, very, very difficult to stop the progression. And the defects around implants are much more severe and difficult to treat, especially if you place the implant in a regenerated bone with many remnants, like bovine bone mineral, like FDBAs, where you have those bone remnants in the site, and the site begin to get infected. At that point, sometimes there is not much you can do. And I'm, again, very, very conservative. I pull out teeth, obviously, that are fractured or have or non-restorable, but never periodontally involved teeth that can be maintained even for 2-3 years.
That's a message that needs to get out, because it's very obvious that the people who've been doing it 30 years don't see implants as a miracle cure for gum disease. But a lot of younger kids
Far
do.
from that.
Far from that. Another question they have is they come out with a lot of student loan debt. They have $285,000, and they see these laser machines, Lanap, for $135,000. Do you think you're a periodontist? Do you buy a Lanap? Do you have a laser? Is that a good investment to treat gum disease?
Not to me.
Not to you?
Not to me. I've used lasers. I once had a laser machine in my office for a trial period. I did not find any real common indications to use the laser. I'm not really updated as of today, but from what I know, there are no indications where you can say only laser can do that, or only laser can be highly successful in that indication.
So, the surfaces have changed. Back in the day, they were hydroxyapatite coated. There was, all kinds of coating deals. Do you think any of the surfaces of the implants are better to prevent peri-implantitis than others?
There are differences in surface treatments and implant designs, and some are more prone to Peri Implantitis, especially when it starts. It's advancing faster in those implants. But to me, the smooth surface implants are probably one of the answers. When we use the smooth surface, the old Brennemark implants, machined titanium, the rate of peri-implantitis was much lower. I still see the implants that I did in the early 90s, the Brennemark implants, and significant difference.
Did you ever meet Mr. Brennemark? Did you ever meet Dr. Brennemark? Professor
Not
Brennemark?
in person, no.
His son is a orthopedic surgeon in San Francisco.
Oh.
Yeah, and
I
I
did
want
not know
to.
that.
Yeah, I'm going to get him on the show. He doesn't do dentistry, but just yeah, I think it's a cool, very fun
So
story.
he followed his father.
Yeah, who was an orthopedic surgeon, exactly, who only did dentistry because it was a lot easier to do research with little spindles in the jaw than trying to replace a mouse's hip or a rat's hip. So in periodontal treatment, you would really recommend to the kids to really try to save the natural tooth as long as you could. Would you almost talk about that more? Because a lot of times they'll see a 3-rooted tooth, a furcation involvement, and they're quick to throw in the towel, pull the tooth, recommend an implant. And your daughter is now followed you into dentistry.
Yes.
What would you coach your daughter and young dentists coming out of school who might be a little quick to give up on the natural tooth and cure it with titanium?
Well, I'm not exactly the right person to judge because I have a lot of experience. I have loyal patients that I tell them that they believe what I say and they follow me up. And they will, if I don't take the tooth out, they will not go across the street to another periodontist. So it's a little bit more difficult to give this type of advice. I would say that from my experience, many years of experience, if you do the right thing, if you do what you learn in school, at the end of the day, it will take maybe longer. At the end of the day, you will be highly successful because patients appreciate it. They understand if you explain it correctly. And to me, and I did the long way. As I said, I didn't do many surgeries at that time. I did only scaling and root planning, which is financially not the best, the best treatment to do. And it paid. It paid.
So I like to call the show Dentistry Uncensored because I want to talk about what people argue about, not what everybody agrees on. Some people argue that when the need for drawing blood and spinning blood for the surgical procedures, and other people say you don't need to do that and it's not supported in the literature. Do you draw blood when you place implants?
I still do sometimes. I used to use it more often in the past. From the literature, this is not supported by the literature. On the contrary, there are several publications that say that there is no difference between using and not using the PRF. Even the sticky bone that is very popular today, probably beyond its physical properties that are easier to handle, there is not much biologic activity in that material. So I use it less and less. If I draw blood anyway, if I do treatments under sedation where you already have an open vein and you can draw the blood easily, it helps and supports soft tissue healing a little bit better than if you do not use it. So that's one of the reasons I use it. I use it in patients with lower healing potential and with higher risk of the procedure. Then I use the PRF. Other than that, I do not see much use for this material.
Some people, for bone grafting, there's now machines that grind up the extracted tooth. So you pull the tooth, you pulverize it, grind it up, and there's your graft. What do you think of that technique?
I'm trying to be politically correct.
No, this is Dentistry Uncensored. That's the whole point of the show.
I
like my guests to answer as if we were drinking a beer at a bar. What's the most?
Since I'm using, I'm also now part of a company that makes biomaterials. To me, it's ridiculous that you trust, so to speak, a dentist in his office and his assistant to take something, grind it, first clean it, then grind it, then disinfect it, and then implant it in the tissue. I trust from what I know about biomaterials, and in this case there is no disease transmission, but there's definitely a risk of infection. And to me, you cannot trust these procedures that are done in the office by inexperienced and I would not say incompetent, but they are not competent to handle biomaterials. And then you actually implant it in the tissue. So to me, this is not the way we should do or get biomaterials. If you harvest bone, it's a different story. It's a living tissue. It's sterile, at least by the time you harvest it. So it's different.
Another controversy, again, I like to stay with where all the arguments are. Some people, when they're treating periodontal patients, they like to use systemic antibiotics, like maybe tetracycline, or local antibiotics, periochips. Is antibiotics a big part of your therapy treatment planning when you're seeing people every 3 months for periodontal disease?
For periodontal disease, I rarely use antibiotics.
Systemic or local?
Systemic. I use local. I'm not really sure about its efficacy. I know that it's supported by the literature, but if you read it carefully, you find out that actually you have to use it in a certain way, in a certain intervals. You cannot just place a one-time device. If you use Arrestin or you use periochip, you need continuous use of the material to be effective. Most of the clinicians are not doing that. They place a periochip or Arrestin once every 3 months when the patient comes in for a hygienist treatment, and this is not effective in those cases. So and as for systemic antibiotics, if you do the mechanical cleaning or disinfection, if you do it properly, in most cases it will work. There are certain indications for additional antibiotics, systemic antibiotics, but in my office, I would say it's almost like 1-2 times a year. That's it.
Another confusing thing to the kids when they get out of dental school is they would think a periodontist spent your whole life trying to save bone, right? And then you go to do an all-on-4, but to make room for the teeth, you level off sometimes a lot of bone. And they see these cases in dental school and they like, well, that's exactly the opposite of everything you told me for 4 years. And now you're just really destroying a lot of bone to make the teeth fit. Well, how do you explain the all-on-4 to now you're eliminating all that bone to make the prosthesis fit? What are your thoughts on all-on-4?
I have never done all-on-4. I'm trying to say it again politically correct.
Don't be. Be the most honoring.
To me, this is not. I would say it like this, and I really believe in that. The original developer of the all-on-4, he has.
Are you talking about Palo Malo?
Yes.
Is that how you pronounce it? Palo Malo? How do you say it?
Palo Malo, I believe.
Out of Lisbon, Portugal?
Yes. And I believe that he did the right things. And because the all-on-4, for example, it's not just the implants. It's probably most important is the occlusion. If you do the occlusion properly, it can last. If you do mistakes with the occlusion, it's not going to last. And you start to lose the implants and lose the bone and everything is lost. So unless you are very, and this looks like an easy way of doing implant cases because you place only 4 implants and you can do it guided, and you can the patient gets the denture cheap and quick. But this, I believe, is a very, very technically sensitive treatment. And if you are not really, really good at what you do and your technician is not really, really good, then you will fail. So this excludes most of the clinicians, including myself, for example. I do not believe that I can do the all-on-4 properly.
And you've placed a lot of implants.
And I place a lot of implants, yes.
So it's a very, how many implants would you guess you place a year?
Well, I used to place many. To me, many implants is between 500 and 1,000 a year. I know the dental surgeons, sometimes they can place thousands of implants, but the number is going down every year because I'm busy with Datum Dental rather than doing implants in my office.
But still, for my audience, I mean, someone who's placed 500 to 1,000 implants.
Today, I place 300 to 400 a year.
That's still a lot, but and even that with all your expertise for 30 years and a periodontist, and we won't hold your Texas training against you. Well, to say that you don't feel comfortable in all-on-4 speaks volumes that it's a. So that's another thing. Do you see now that when back in the day you tried to get the longest implant in that you could, and now implants are going shorter, fatter. Do you see yourself doing less sinus lifts because implants are getting shorter and fatter?
Definitely, I believe in short implants. As long as the implant is of good quality, and again, the occlusion. If you overload the implant, any length of implant, you will lose the implant eventually. If the load is in the wrong direction, you will lose the implant over time. You lose bone, and then you lose the implant. So short implants work, but again, technically sensitive, especially for the restoration.
I'm always glad to hear any good news about anything short and fat. I'm very pro short and fat. Well, what you said is profound because that's why Carl Misch got into implants. He was doing dentures first, and when he was building his dentures, he was looking at these people complaining that something was wrong with the implants because they were breaking. And he said it had nothing to do with the implant. It was your bite was horrible. So he thought his foundation of learning how to get a proper bite with full removable was the most important part of his foundation to go into implants. And he agrees that a lot of people are doing implants that don't understand occlusion, which is another question I want to ask. In dentistry, they say there's 3 diseases: cario, perio, and occlusion. But it seems like when kids come out of school, they know the most about caries, and then perio, but not as much as about occlusion. Why do you think occlusion is so much of a more difficult concept than, say, caries?
I remember myself in the occlusion classes. We had one of the best teachers. He was a renowned name in the whole world. It was so boring that we were half asleep, when the 10 minutes after the class started. So it's kind of you cannot really hold it, feel it, see it. So it's something that it takes a good teacher, but a lot of practice with someone who know and can teach you what to do. And this is something that most of us do not have the luxury to have this kind of training.
Yeah, and I think it's also like measurements. Like you can see 10 cavities on the X-rays and chart them. periodontal disease, you can probe and chart them. And now it looks like because of Invisalign, all the clear aligners, artificial intelligence, looks like they're finally developing a clear aligner artificial intelligence measurement for occlusal disease. And so there's a couple of different camps that think that they're going to have an objective AI measurement, and I think that will be a game changer in occlusion, because if all the measurements are bite down on paper and you're looking at it, but you can't see it on a radiograph, you don't have a measurement. So I think if you know, like Invisalign, they Line Technology owns Invisalign and they own iTero. So they have all those iTero scans. They have the biggest data set, and they think they have a measurement for occlusal disease. Do you think that would be a game changer?
It is, definitely.
Yeah.
Definitely. This is something where all this computerized dentistry, I would call it, can be really, really helpful.
Yeah. My family is really looking forward to artificial intelligence because our natural intelligence didn't do too well. So we're really looking forward to artificial intelligence. I want to thank you so much for coming by. I know humans love to see. So if you ever want to post some cases on Dental Town so they can see, or the thing, you know, back in our day, it was always an all-day lecture, a lot of times fly to another city. Millennials today love an hour online course, but if you'd ever have the time to make an hour online CE course, I'm Howard at Dental Town, but the guy in charge of CE is Howard Goldstein. So he's Hogo at Dental Town, but millennials love hour-long courses, and all of our courses are ADA approved, AGD approved, but it'd be a real honor if you ever had time to write us an article or an online course or anything like that. Yuval Zubery, DMD, Chief Medical Officer and Co-founder at Datum Dental, thank you so much for coming by and talking to the dentist today.